polycystic ovarian syndrome, because the word syndrome is there, you do understand that syndrome means there is more than one symptom involved. And generally it is more than one organ system also involved. That's how it becomes a syndrome. So when we say polycystic ovarian syndrome, it is not just the ovaries involved, but also certain other body systems which are connected to the ovary in a certain way are also involved. And the classical symptoms that somebody would, young girls, it generally begins around the time of puberty. So 13, 14, 15, 16-year-olds, it is common. Then in the early 20s, it is more common than as compared to in the later age groups. That's when it's first diagnosed. And what the girls would classically present with is they have acne on the face, excessive hair growth in various parts of the body. At the same time, there is hair loss from the scalp. And because of this reason, the first presentation would generally be to a dermatologist, because everyone is concerned about their appearance. And so if the face starts looking pimply and ugly, and there are hair coming at the sideburns and the upper lip and things like that, and you have hair loss from the scalp, the first person you probably think of visiting is not a gynecologist, but rather a dermatologist. And the dermatologist will give you a very fancy prescription of about 15 different kinds of preparations, some topical, some to be eaten, some precautions to be followed, some places you not go out in the sunlight, don't go out after 5 p.m. and all these kind of vague things. And they would try this for a while. And what would happen is that after 1 or 2 months, they would see that, okay, it's helped us maybe 10-20%, but that's about it. That's because the underlying problem hasn't been treated. So only the symptom has been treated. The second common symptom is obesity. In fact, obesity is the most common symptom after acne and the hair problems. And generally, obesity is the one that triggers the balance, or rather the disbalance of hormones. Because you may have read this again in the MBBS times, that fat is also a factory for hormones. So the greater the body fat, the greater hormones are released. And that's how the balance in PCOD from the normal hormonal value in a woman's cycle is disturbed. And when that happens, they present with irregular cycles or sometimes even heavy bleeding. And if they are around maybe the age of 25, 30, they have already been married with these problems, they would come with infertility. And these are also because of the increase in the male counterpart of hormones. So it's usually it's a kind of a long-term condition. So there's no quick fix to PCO. It takes some time to develop. It will develop generally over months or years. And when we start treating for it, also the first thing we tell them is that it's not a magic wand. So even the medicines that you are going to take now will start showing some effect. Will take at least 3 months to start showing some effect. So they need to have a kind of realistic perception of what treatment is going to look like. So that is about PCOS. Now, this is from more of a theoretical point of view. WHO has classified oligo or anovulation into three classes, basically. The first one is where there is a dysfunction at the level of the hypothalamus and the pituitary. And so what happens is that the hormones which are going to stimulate the ovarian hormones, namely FSH and LH, are not released in appropriate amounts from the pituitary. And that is why they don't act on the ovary appropriately. And that's why the ovarian production of the ovarian hormones, which are estrogen and progesterone, suffers. So that is when the defect is central. It is not in the ovaries, but it is because of problems at the hypothalamo-pituitary level. And so in these cases, they would have classically low FSH, low LH, and low estrogen levels. The second form is the normogonadotrophic, normoestrogenic. Now, in this case, this is what is classically PCO, where there is a disbalance in the axis itself. So the hormone levels may not be very abnormal, but the anovulation is occurring because of a disbalance in this axis, hypothalamo-pituitary ovarian axis. The third one is the hypergonadotrophic, hypoestrogenic, where the organ involved is the ovary, in that it does not respond to the FSH and LH levels by the pituitary. So basically, that is generally seen in, let's say, in Turner's or in gonadal dysgenesis, where there is end organ failure. So the ovary does not produce its hormones, but the stimulus from the pituitary and the hypothalamus keep on going. So FSH and LH levels will be high, but E2 levels will be low. So this is what it is. And basically PCO, you can say PCO is synonymous with anovulation. 75% of the anovulation cases are because of PCO. Anovulation, you understand, means ovaries are not ovulating as they do, releasing an egg in the middle of the cycle. Now, these are the latest guidelines from 2018 regarding the evidence-based management of PCO. Mind you, guidelines have been around since early 2000s. Like when I was a medical student nearly 20 years ago, the guidelines were entirely different. More and more things are added to it. And this is the latest one. And what it basically says is that PCO is because it's a syndrome, it's a triad of three things basically. And at any given time, 2 out of the 3 things should be present to diagnose someone as PCO. So the first one is hyperandrogenism. So features of hyperandrogenism, which are either clinical or biochemical. I will come to the detail of it in a minute. Then ovulatory dysfunction. That dysfunction could be oligoovulation. So that means delayed cycles, or anovulation, where there are almost no cycles. And then the third part is the polycystic ovaries, which are seen on ultrasound. And there is also a size and a volume criteria for this. So at any given time, at least 2 out of the 3 need to be present to diagnose someone as PCO. What happens more commonly is that ultrasound being done for any other reason, for example, shows the ovaries as multicystic. Now, in young girls, ovaries can often be multicystic. So they are misinterpreted as polycystic, and that's how these girls are labeled as PCO when actually they may not be having any other feature. So that's why it's very important to know the criteria to diagnose it accurately. Now, I spoke about clinical and biochemical hyperandrogenism. Clinical hyperandrogenism will reflect in the form of hirsutism, which is increased body hair at the back, chin, let's say, breast area, abdomen area, sideburns, those kind of things. Acne, again, over the face, over the body. Seborrhea on the scalp, then male pattern balding. So you start losing hair from the front and the sides like in males. Then increased muscle mass, deepening of voice, and clitoromegaly. These are features of increased androgen circulating in the blood. Biochemical hyperandrogenism, you will know by means of tests that you will carry out. So levels of serum testosterone, of free testosterone, free androgen index, which is more sensitive than either of these levels. Then dehydroepiandrostenedione. These are all ovarian hormones. These are also adrenal hormones, but androstenedione is another one. So these are the levels you would test for to confirm that yes, indeed, there are male hormones circulating in the blood. And for polycystic ovaries on ultrasound, generally the criteria is fixed. So there should be at least 20 follicles of 2 to 9 millimeters. So not big follicles, small follicles, antral follicles. And the combined ovarian volume should be at least 10 ml. And while measuring, you should not measure other things like a corpus luteum or a cyst or any other dominant follicle in the ovary. And because ultrasound is a very kind of sensitive tool, so you need a transvaginal ultrasound to actually pick up growing follicles in the ovary. It's very difficult to do so on an abdominal ultrasound.